Imagine for a second that you are trying to drink a thick, really heavy milkshake.
Right.
But suddenly your brain has completely forgotten how to send the electrical signal down to your throat muscles, telling them to actually swallow.
Yeah, just totally offline.
Exactly. And simultaneously, while that thick liquid is just pooling in the back of your mouth, you still have to draw air into your lungs to survive. The liquid and the air are both fighting for the exact same, anatomical highway.
It's a terrifying scenario.
It really is. And for 97% of babies born with PURA syndrome, this is not some abstract thought experiment. This is the terrifying, overwhelming reality of their very first moments of life.
Right. It is an incredibly dangerous mechanical failure. And it immediately thrusts families into a medical crisis that centers entirely around the most basic human necessity, which is feeding.
You look at a newborn, and feeding is supposed to be this quiet, instinctual bonding experience. But when you step into the world of rare neurodevelopmental genetics, those instincts are completely hijacked by biology.
Completely.
If you are listening to this right now, the parents, the grandparents, the daily carers of a PURA warrior, you know this reality. You live it every single day. We are speaking directly to you today.
Absolutely.
We know that caring for a child with PURA syndrome is a journey of profound joy and fierce unconditional love. But we're also going to acknowledge the hard truth, which is that the daily, relentless mechanics of feeding, hydration, and nutrition can be the most stressful part of your life.
It is often the absolute heaviest weight the caregivers carry. Because it isn't just about putting food in the stomach. I mean, it involves navigating a cascade of interconnected systems that are simply failing to communicate with one another.
Right. And that is exactly our mission for this deep dive. We're going to unpack the complete, unvarnished picture of feeding and nutrition in PURA syndrome. We're looking at the journey from those terrifying early days in the neonatal intensive care unit all the way to long-term management in childhood and adolescence. We're going to explore the mechanics of exactly why feeding is so incredibly difficult, how interventions like NG tubes and permanent peg feeds actually work, and how the entire digestive system, from the muscles in the mouth all the way down to the smooth muscle of the intestines, is impacted by this specific genetic difference.
And the daily management, too.
Yes, the daily strategies you handle, like working with thickeners to prevent aspiration, tailoring customized tube feeding diets, balancing sodium and hydration, and ensuring your child's bone health doesn't just silently deteriorate.
To do this properly, we have synthesized a massive stack of medical literature and support resources.
It's a big stack today.
It really is. We are pulling directly from comprehensive clinical care guidelines, cutting-edge cellular research from the Florey Institute in Australia, the invaluable patient registries compiled by the PURA Syndrome Foundation, the latest diagnostic criteria from Gen Reviews, and even some newly published fascinating case studies detailing specific dietary interventions, like the ketogenic diet.
Our goal is to take that mountain of dense medical literature and translate it into knowledge that empowers you. If you are in the trenches of mixing formulas and managing tube feeds, we want you to understand exactly what is happening inside your child's body.
And what's fascinating here is that to truly understand the feeding difficulties in PURA syndrome, we have to completely overhaul our standard view of digestion.
Right, because we normally just think about the stomach.
Exactly. We are taught in school to view eating as a purely gastrointestinal process. You chew, you swallow, the stomach acid does its job, and the intestines absorb the nutrients. But in PURA syndrome, feeding is fundamentally a neurological issue.
Okay, so it starts in the brain.
Yes. Today, we are going to trace the path of a specific protein deficit starting deep within the brainstem, and we are going to follow the fallout of that missing protein all the way down the physical body to see why your child's muscles respond the way they do.
That framing is so vital because it dismantles the guilt that so many parents carry. If your child is struggling to latch or constantly choking on thin liquids or violently resisting a new texture of food, it is not because you aren't trying hard enough.
No, not at all.
And it is not because they are just being difficult. It is pure biology. Let's look at the sheer scale of this. When we examine the clinical registries, the prevalence of feeding difficulties in this population isn't just common, it is nearly universal.
It's staggering.
Over 80% of all neonates with PURA syndrome have profound feeding issues, and the more recent longitudinal studies suggest that number is actually closer to 97%.
It is considered a defining hallmark of the condition's onset. Clinicians actively look for a very specific triad of symptoms in the neonatal intensive care unit.
The triad.
Right. When a baby with PURA syndrome is born, they almost always present with severe hypotonia, which is exceptionally low muscle tone. Then respiratory insufficiency, meaning the brain isn't signaling the lungs to breathe effectively. And finally, significant life-threatening feeding difficulties.
So we have to go down to the molecular level to understand why this specific triad occurs, because clearly the breathing, the floppy muscles, and the inability to swallow are all connected to a single root cause.
They all originate on chromosome 5. If we look at the microscopic architecture of our DNA, there is a specific address designated as 5q31.3. This locus is the home of the PURA gene.
Right.
And the entire purpose of the PURA gene is to act as an instruction manual for the body's cellular machinery, telling it how to manufacture a single, highly specialized protein called Pur-alpha.
And what makes the Pur-alpha protein so crucial that missing it causes a newborn's entire respiratory and feeding system to crash?
Well, Pur-alpha is what we call a highly conserved multifunctional protein.
Highly conserved, meaning
That evolution has kept this protein virtually identical across many different species because it is so fundamentally essential for life.
Oh, wow. Okay.
Yeah. While it is present in almost all human tissues, its role is vastly pronounced in the central nervous system. It regulates how neural cells multiply and grow. It helps mature the dendrites, which are the branch-like structures that neurons use to send and receive electrical signals to one another. But its most critical function is acting as a molecular courier.
A courier, so it's physically moving things around inside the brain's cells.
Exactly. Inside a neuron, the DNA in the nucleus writes out genetic instructions in the form of messenger RNA, or mRNA. But those instructions are totally useless if they stay in the nucleus.
They're just trapped.
Right. They need to get to the outer edges of the cell, out to the synapses, to actually build the architecture of the brain. Pur-alpha binds to this mRNA, packs it up, and physically transports it down the long arms of the neuron to the translation sites.
That's incredible.
It really is. This process is absolutely vital for synaptic plasticity, memory formation, and the basic wiring of the brainstem.
I want to make sure I'm fully grasping the genetics here, because the clinical paperwork parents receive is incredibly dense. The reports often say things like heterozygous pathogenic variant, or they list terms like frameshift, missense, or microdeletion. What do those terms actually mean for the production of this courier protein?
Let's break those down because they are the blueprints of the condition. We all inherit 2 copies of the PURA gene, one from our mother and one from our father.
Okay.
Heterozygous means that only one of those 2 copies has a variation. One copy is perfectly normal, but the other is pathogenic, meaning it causes disease. Because one copy is offline or corrupted, the body only produces half the normal amount of the Pur-alpha protein.
Right, so you're running on half power.
Exactly. The medical term for this state of operating on half capacity is haploinsufficiency.
So the brain only has half the couriers it needs to deliver the blueprints. And the actual typo in the DNA can take different forms, right?
Yes, it can. A missense mutation is like taking a single word in a sentence and swapping it for another word. It might change the meaning of the sentence entirely, resulting in a Pur-alpha protein that is folded incorrectly and just can't do its job.
Okay. What about a frameshift?
A frameshift mutation is much more disruptive. Imagine deleting a single letter from a sentence, which forces all the subsequent letters to shift over one space.
Oh, wow.
Right, from that point on, the entire rest of the sentence becomes absolute gibberish. The cellular machinery reads the gibberish, realizes it's useless, and it destroys the protein before it can even be used.
And a microdeletion?
A microdeletion is like tearing an entire page out of the manual. The PURA gene and sometimes a few neighboring genes are simply physically missing from the chromosome.
That's drastic.
Very. But the end result of all 3 of these genetic typos is identical. The developing brain is trying to build its incredibly complex networks of breathing, moving, and swallowing, but it is constantly running out of building materials and couriers.
Okay, so the brain's communication infrastructure is chronically under-resourced. How does that translate to the physical body of a newborn baby? Like, how do we get from a missing protein in the brain to a baby whose body feels completely limp when you pick them up?
The direct physical manifestation of this neurological deficit is central hypotonia. You will often hear clinicians refer to it informally as floppy baby syndrome.
Right, floppy baby.
The muscle tone is profoundly low. The infant cannot maintain posture. They struggle to lift their arms or legs against the basic force of gravity, and they literally feel like a rag doll in your arms.
I think a good way to conceptualize this is to think of the body as a smart home system. You have perfectly functioning hardware, The physical muscles of the baby's mouth, their throat, their chest wall, their legs, those muscles are built correctly. There is absolutely nothing wrong with the physical muscle fibers themselves.
That's a great analogy.
Right, but the brain is the central Wi-Fi router. The router is trying to send a wireless signal telling the muscle to contract, but because of the lack of Pur-alpha, the signal is incredibly weak. It's dropping packets of data.
Exactly.
So the message reaches the muscle, but it doesn't have nearly enough voltage or clarity to cause a firm, coordinated, sustained contraction.
That is the exact mechanism. It is a signaling and control issue originating from the central nervous system, which is why we specify it as central hypotonia, rather than a defect in the peripheral muscle tissue.
Wait, that raises a huge question for me. If a baby is born and they are completely limp, their muscles are entirely floppy and they can't move,
Yeah.
why wouldn't a doctor look at that baby and immediately assume it's a primary muscle disease, like spinal muscular atrophy or muscular dystrophy? Why do they suspect the brain instead of the bicep?
That is the exact diagnostic puzzle that neonatologists face in the first days of life. And it's why getting a PURA syndrome diagnosis can sometimes be delayed. However, the sources highlight a very specific, fascinating clinical clue that doctors look for during an examination.
Oh, really?
Yeah. Unlike peripheral neuromuscular disorders like muscular dystrophy, where the muscle tissue itself is wasting away, deep tendon reflexes are typically preserved in infants with PURA syndrome.
You mean like when the doctor taps your knee with the little rubber hammer?
Precisely. The knee-jerk reflex is an automatic loop. When the doctor taps the tendon, the sensory nerve sends a signal to the spinal cord, and the spinal cord immediately sends a signal back to the leg muscle to kick.
Oh, so it doesn't go all the way up to the brain.
Exactly. That specific reflex arc doesn't require complex input from the brain's higher processing centers. So if you tap the knee of a baby with PURA syndrome, their leg will often still kick.
Because the peripheral nerves and the physical leg muscles are perfectly intact and capable of firing.
Yes, the hardware works.
Yeah.
The issue only becomes apparent when the brain attempts sustained, voluntary, or complex automated movements like breathing rhythmically or coordinating a swallow. Those actions require massive, coordinated processing power from the brainstem and the cerebral cortex, and that is exactly what is impaired by the lack of Pur-alpha.
That distinction makes perfect sense. The brain just can't orchestrate the complex symphony. And this leads us directly to the most immediate, terrifying hurdle that families face in the newborn phase. Because of that weak Wi-Fi signal, the intricate choreography required to safely consume milk completely breaks down. Let's talk about what happens in the neonatal period, specifically focusing on dysphagia.
Dysphagia simply translates to impaired swallowing. And to understand why dysphagia is so uniquely dangerous for a newborn, we have to look closely at the mechanical complexity of how an infant feeds. Adults take swallowing for granted, but an infant feeding is performing an astonishingly sophisticated biological sequence known as the suck, swallow, breathe cycle.
We mentioned the anatomical highway earlier. It's a crowded intersection. The baby has to pull liquid into their mouth, send it down to the stomach, but simultaneously keep drawing oxygen into their lungs. And the pathways for the lungs and the stomach cross paths right in the back of the throat.
I like to visualize it as a highly complex railway switchyard.
Oh, a switchyard.
Right. You have tracks carrying liquid and tracks carrying air. A baby must seamlessly suck the fluid from the nipple, use their tongue to marshal that fluid into a cohesive liquid ball, which we call a bolus, and push it to the back of the throat.
Okay, so the fluid is moving back.
Yes. And at the exact millisecond the liquid approaches, a flap of cartilage called the epiglottis must slam shut over the trachea, the windpipe, to protect the lungs. The liquid slides over the closed epiglottis and down into the esophagus, the feeding tube.
And then it has to open again to breathe?
Exactly. The milliseconds the liquid passes the epiglottis must spring back open so the baby can take a breath. And they have to execute this switching mechanism rapidly, rhythmically, over and over again without a single pause.
It's a railway switch that has to flip back and forth flawlessly dozens of times a minute. It requires immense strength in the lips, the cheeks, the tongue, and the pharynx, and all of those muscles have to be perfectly timed by the brainstem. But for a PRA warrior with central hypotonia,
The weak central signal means the entire switchyard goes out of sync.
the timing is off.
Exactly. The lips might not have the tone to form a tight vacuum seal on the nipple. The tongue might be too weak to push the liquid backward in a controlled manner. And most critically, the signal telling the epiglottis to snap shut over the airway is delayed. It closes too slowly, or it doesn't close completely.
And when that tract to the lungs is left even slightly open while the liquid is coming down?
The milk or formula goes down the wrong pipe. It breaches the trachea and enters the lungs. This is known as aspiration.
Which is terrifying.
Extremely. When foreign fluid enters the sterile environment of the lungs, it triggers massive inflammation and carries an incredibly high risk of aspiration pneumonia. For a neonate with PURA syndrome who is already dealing with respiratory insufficiency and central apnea, aspiration pneumonia can be rapidly fatal.
Think about the sheer physical effort of this. Imagine trying to drink a thick milkshake through a narrow straw, but all the muscles in your cheeks and throat are completely, totally relaxed. You have to strain with everything you have just to move the liquid.
It's exhausting.
A hypotonic baby is expending massive amounts of caloric energy just trying to execute the suck-swallow-breathe cycle, and because the mechanics are failing, they aren't safely taking in enough calories to replace the energy they just burned. They exhaust themselves into a deficit.
Which is why medical intervention in the NICU is almost always swift and necessary. The clinical guidelines in our source stack explicitly state that to prevent aspiration pneumonia and ensure basic survival, neonates with PURA syndrome frequently require immediate nutritional support via nasogastric tubes.
The NG tube. This is a thin, flexible plastic tube that is threaded in through the baby's nostril, pushed down the back of their throat, down the esophagus, and directly into the stomach.
Right.
And we really need to pause here and acknowledge the emotional shockwave this sends through a family. You have spent 9 months picturing those first days of life. You picture holding your baby, nursing or bottle feeding, experiencing that quiet, primal bonding.
That's the expectation, yes.
Instead, the reality is a brightly lit NICU, surrounded by the constant alarms of oxygen monitors, and your tiny, fragile newborn requires a plastic tube taped to their face just to receive basic hydration and calories. The sensory environment alone is traumatizing, let alone the fear that your child might choke on their own saliva.
The disruption of parental expectations is profound, but it is vital for caregivers to reframe how they view the NG2. It is not a barrier to bonding, and it is certainly not a medical defeat. It is a vital, life-saving bridge. Yes, the NG tube entirely bypasses the neurological disconnect happening in the throat. It allows the infant to receive fortified breast milk or specialized formulas directly to the gut, ensuring their brain and body have the absolute necessary caloric energy required to develop, completely removing the exhaustion and the severe risk of drowning their lungs.
Often when families have a baby in the NICU with hypotonia, they're told by well-meaning doctors that the baby might just need time to wake up, or that they will grow out of this floppy phase as they gain weight. But the literature makes it very clear that with PURA syndrome, this is rarely a passing neonatal phase.
When we look at how this plays out in a child's life over years, what we call the clinical phenomenology, we see a distinct pattern. Some neonatal symptoms do eventually resolve. For instance, the profound hypothermia some babies experience, or the severity of the central apneas, often stabilize after the first year of life as the brainstem matures slightly.
Okay, so that improves.
Right, but the central hypotonia is foundational. It is persistent. Because of this, for many children with PURA syndrome, the swallowing dysfunction, the dysphagia, proves to be a chronic, long-term reality.
Which brings families to a major, often incredibly difficult crossroads. When the medical team realizes that an NG tube is no longer a viable long-term option, what happens next? Because you can't leave a tube taped to a child's nose indefinitely as they become toddlers.
When it becomes evident that safe, sufficient oral feeding is not going to be achieved in the short to medium term, the standard of care is to transition from the temporary nasal tube to a permanent surgical solution. This involves the placement of a gastrostomy tube, which you will hear referred to as a G-tube or a PEG feed.
PEG stands for percutaneous endoscopic gastrostomy. Let's explain the mechanics of this, because the idea of surgery on an infant is terrifying. How does a PEG tube actually work?
Well, a gastroenterologist or a pediatric surgeon uses an endoscope, a thin tube with a camera passed down the throat into the stomach, to shine a light against the inside of the abdominal wall.
So they can see exactly where they are.
Exactly. This allows them to see exactly where to make a small, precise incision from the outside of the belly. They then insert a medical-grade feeding tube directly through the skin and into the stomach. A small balloon or a silicone bumper is inflated inside the stomach to hold the tube securely in place, and a small, discreet button rests flat against the child's skin on the outside.
The psychological hurdle of agreeing to surgically alter your child's body so they can eat is massive. But the clinical literature strongly frames the G-tube not as a failure, but as a crucial stabilizing liberation.
Is transformative for the family's daily life. A G-tube permanently eliminates the daily trauma of accidentally dislodging and reinserting NG tubes, which chronically irritates the sensitive mucosal lining of the nasal passages and throat.
Right, that constant changing is awful.
It really is. It ensures absolutely precise, guaranteed caloric and fluid intake. It supports sustained, healthy growth, which is critical because a brain cannot myelinate and develop if it is starving. And most importantly, it permanently bypasses the vulnerable airway, drastically and permanently reducing the risk of aspiration pneumonia.
You transition from fighting a terrifying high-stakes feeding battle every 3 hours to being able to calmly administer nutrition, exact levels of hydration, and crucially, medications, directly into the stomach through the button.
Exactly.
But of course, because PURA is a multi-systemic genetic condition, the stomach isn't just an isolated, perfectly functioning bag. The low muscle tone doesn't magically stop at the bottom of the esophagus.
That is a critical point. The central hypotonia affects the smooth muscle tissue of the entire gastrointestinal tract. And one of the most pervasive, dangerous complications highlighted across the diagnostic paradigms is gastroesophageal reflux disease, or GERD.
Now, almost all babies spit up. It's a running joke about parenthood and burp cloths. But when we talk about GR in PURA syndrome, we are talking about something much more severe than normal infant spit up.
Yeah, significantly more severe. At the very bottom of the esophagus, just before the stomach, there's a muscular ring called the lower esophageal sphincter. It acts as a one-way valve.
Right.
It opens to let food drop into the stomach, and then it's supposed to clamp tightly shut to keep the corrosive stomach acid from splashing back up.
Oh.
But because of the central hypotonia, that sphincter muscle is incredibly weak. It remains lax and open, so the highly acidic contents of the stomach easily and constantly wash back up into the esophagus.
Which burns. It causes intense pain, heartburn, and chronic irritability. You often have babies arching their backs in pain after feeds.
It causes profound discomfort. But the real danger lies in how the digestive system interacts with the respiratory system. If we connect this reflux to the bigger picture of the PURA phenotype, GERD actively and dangerously exacerbates the respiratory distress. Remember, over 50% of PURA neonates face significant respiratory instability, including recurrent central and obstructive apneas, where they simply stop breathing.
Wait, let me stop you there. How exactly does stomach acid splashing up the throat make a baby stop breathing? What is the mechanical link there?
It comes down to the vagus nerve, which runs from the brainstem down through the neck and into the abdomen, controlling both the heart rate and the airway. When that stomach acid reflux is high enough into the esophagus, it severely irritates the vagus nerve.
Wow.
Yeah. Sometimes, the microdroplets of acid reach the very top of the throat and threaten to enter the airway. The brain's primitive defense mechanism against this acid destroying the delicate lung tissue is to trigger an immediate, violent airway spasm.
To protect the lungs.
Exactly. The vocal cords and the airway clamp completely shut to protect themselves from the acid.
So the body's attempt to protect the lungs from the acid actually causes the child to stop breathing entirely.
Yes. The acid reflux literally triggers an apneic event. The child turns blue. It creates a terrifying, vicious cycle where the weakness of the digestive valve compounds the instability of the respiratory system.
So how do you manage a valve that won't stay closed?
It requires aggressive medical intervention. The first line is often pharmacological, using high doses of proton pump inhibitors. These drugs fundamentally alter the stomach's chemistry by blocking the enzymes in the stomach wall that produce stomach acid.
Making it less acidic.
Right. By drastically lowering the acidity, even if the fluid splashes up, it doesn't burn the esophagus or trigger that severe airway spasm.
But what if the medication isn't enough? What if the physical volume of the reflux is just too high?
In severe refractory cases, a surgical procedure called a Nissen fundoplication might be performed, very often in tandem with the initial G-tube placement.
Let's explain the mechanics of a fundoplication because it sounds like a complex plumbing fix.
It essentially is. The surgeon takes the very top part of the stomach, known as the fundus, pulls it up, and physically wraps it around the outside of the lower esophagus, stitching it in place. It acts like a tight, supportive collar.
Ah, I see.
By wrapping the stomach around the esophagus, it physically reinforces that weak, hypotonic sphincter muscle, creating a high-pressure zone that makes it virtually impossible for stomach contents to travel backward.
Now, anytime we discuss surgical interventions for a PURA warrior, whether it's placing the G-tube button or performing the fundoplication or both, we absolutely have to address the anesthesia risks. Because putting a child with this condition under general anesthesia is a major specific concern for the medical community.
Yes, absolutely.
The orphan anesthesia guidelines we reviewed are incredibly explicit about the unique challenges these patients present in the operating room.
It is a paramount safety issue. The guidelines state unequivocally that patients with PURA syndrome have an extreme, exaggerated sensitivity to respiratory depressant medications. When an anesthesiologist is inducing sleep for surgery, they use an intricate cocktail of drugs, including opioids for pain management.
Right.
But opioids naturally suppress the brain's drive to breathe.
And because a child with PURA syndrome already has a compromised brainstem that struggles to maintain a steady respiratory rhythm, giving them a standard weight-based dose of a respiratory depressant is incredibly dangerous. The signal to breathe might just completely shut off, and they might fail to start breathing on their own again as the anesthesia wears off.
Exactly. The guidelines mandate that anesthesiologists must aggressively minimize the use of opioids, sometimes reducing standard doses by up to 50%, and relying more heavily on regional nerve blocks or non-opioid pain management.
That's a huge reduction.
It is. Additionally, the autonomic nervous system, the system that controls automatic body functions like temperature regulation, is frequently dysregulated in PURA syndrome.
Meaning they can't regulate their own body heat.
Correct. The cold environment of an operating room, combined with the anesthesia, creates a high risk for profound intraoperative hypothermia. The surgical team must utilize active thermoregulation protocols like forced air warming blankets and warmed intravenous fluids to keep the child's core temperature stable during the procedure.
And the risk doesn't end the second the surgery is over, right?
Not at all. Post-operatively, the guidelines mandate a minimum of 24 hours of intensive inpatient monitoring. There's a deeply elevated risk of post-anesthetic apnea or hypopnea, which is abnormally shallow or slow breathing.
Wow, so you have to stay incredibly vigilant.
Yes. The guidelines also strongly recommend the prophylactic use of a nasopharyngeal airway during the recovery phase. This is a soft rubber tube inserted through the nose down to the base of the tongue, which physically splints the floppy hypotonic upper airway open so it doesn't collapse as the child wakes up and their muscles are at their most relaxed.
Having this knowledge is so empowering for a caregiver. It allows you to walk into a pre-surgical consult and say, have you reviewed the orphan anesthesia protocols for PURA syndrome? Are you prepared to manage the hypothermia risk and the opioid sensitivity?
It really does.
It changes the dynamic from passive anxiety to active advocacy. But I want to pivot back to the daily reality of living with a G-tube, because there is a very common misconception out there. Many people assume that once a G-tube is placed and all the nutrition is going directly into the stomach, the child never uses their mouth muscles again. Do we just abandon oral feeding and mouth movement entirely?
Absolutely not. In fact, it is the exact opposite. The presence of a G-tube does not mean the end of oral motor development. It simply means the pressure is off.
Yeah.
Because the baseline nutrition and hydration are secured, therapists can push the oral muscles to work harder without the fear of the child starving.
And that leads us to the crucial role of active relentless therapies. Even with tube feeding, handling the heavy lifting of caloric intake, the medical consensus is incredibly clear. Oral motor dysfunction must be actively managed.
It must be.
The sources, including the comprehensive resources from specialized intensive therapy clinics like the Napa Center, emphasize intensive feeding therapy.
This therapy is typically overseen by a multidisciplinary team, relying heavily on occupational therapists and speech-language pathologists. The primary goal isn't necessarily to get the child to eat a cheeseburger. The goal is to maximize whatever functional neurological capacity the child possesses.
Right.
Even if a patient is never able to safely consume a full, calorically sufficient meal by mouth, improving the resting muscle tone in the lips, jaw, and tongue is absolutely essential for managing their own oral secretions.
Right, because we constantly produce saliva, and if the brainstem isn't triggering the swallow reflex every few minutes to clear that saliva, it just pools in the mouth. This leads to sialorrhea or excessive drooling, and while drooling might sound like a minor issue compared to seizures or apnea, it is a huge quality of life issue.
It really is.
It can cause chronic, painful skin breakdown on the chin and chest. It requires constant clothing changes, and as the child gets older, it can become a significant social barrier.
Precisely. To combat this, therapies like those pioneered at the Napa Center focus on global motor improvement. They recognize that the body is a kinetic chain. You cannot have fine motor control of the tiny muscles in the jaw and tongue if you do not have gross motor stability in the core and the neck.
The trunk of the body is the anchor for the head. If your core is floppy, your head is going to loll around. And if your head isn't stable, your jaw doesn't have a solid anchor to pull against to close your lips.
That is a perfect biomechanical summary. So a feeding therapy session might start with intense physical therapy focused on sitting up straight and stabilizing the shoulders before the therapist even touches the child's face.
Now, when therapists do start introducing tiny tastes or working towards managing small amounts of safe oral intake, it's not just about muscle strength. The sources note that PURA patients often have profound systemic sensory regulation issues.
Yes, very common.
We often hear about this regarding their hearing the pathological startle response to sudden noises, but it severely impacts feeding because they also have hypersensitivity to textures.
We have to remember that the human mouth is one of the most sensory-rich areas of the entire body. It is packed densely with millions of nerve endings specifically designed by evolution to detect minute changes in temperature, texture, and taste.
To protect us, right.
Exactly. This is a survival mechanism to protect us from choking on a bone or ingesting a toxic plant. But in a child with a neurodevelopmental disorder like PURA syndrome, the processing of this massive influx of sensory information is highly disorganized.
And this is where the daily reality for parents gets incredibly complex. Feeding therapy for a PURA child isn't just about learning to eat in the traditional sense. It's like intense physical therapy combined with high-stakes sensory integration. You are slowly, painstakingly trying to convince a highly sensitive, hyperreactive nervous system that a slightly lumpy texture on the tongue is not a life-threatening event.
Exactly. In a neurotypical child, the brain quickly maps and categorizes new textures, seamlessly adjusting to the transition from smooth, pureed baby food to soft solids. But for a child with PURA, a sudden, unexpected change in texture on the tongue can trigger a violent gag reflex, extreme distress, or total behavioral refusal. The disorganized nervous system reads the lumpy texture, panics, and rings a massive alarm bell.
Which brings us to the very specific, meticulous management of textures that parents handle daily, specifically working with commercial thickeners. Because even if a child is approved by their medical team for a tiny amount of oral intake, maybe just tasting a liquid for pleasure, thin liquids like water, regular milk, or standard juice are incredibly, uniquely dangerous for a hypotonic airway.
They are the most dangerous consistency. Thin liquids move incredibly fast, and they are entirely unpredictable.
Like trying to catch water with your hands.
Right. If the swallowing reflex is delayed by even a fraction of a second due to the weak brainstem signal, a thin liquid will rush past the back of the tongue and spill directly into the open trachea before the epiglottis has had time to snap shut.
So, to manage this, speech pathologists will perform rigorous swallow studies. Often this is a modified barium swallow where the child is fed liquids laced with barium while being x-rayed in real time.
Yes.
The clinical team watches the liquid move down the throat on the monitor to see exactly what thickness of liquid the child's muscles can successfully manage without aspirating. And from that point on, parents become meticulous medical caretakers of consistency. You are constantly measuring and adding commercial thickening powders to every single liquid that enters your child's mouth, aiming for a very specific, clinically prescribed consistency.
Whether the prescription is for nectar thick, honey thick, or pudding thick, the goal is mechanical. The thickener increases the viscosity of the liquid. It slows the fluid down as it moves over the back of the tongue. It acts as a cohesive unit, giving those hypotonic, slowly reacting muscles the extra milliseconds they desperately need to coordinate the closure of the airway and execute a safe swallow.
It is a relentless, vital daily task. Every glass of water, every taste of juice has to be perfectly calibrated. But beyond safety, there is a secondary, deeply profound benefit to this oral motor therapy. Strengthening the mouth ties directly into one of the most visible and challenging aspects of the PURA phenotype, which is communication.
The gap between what these individuals understand and what they can verbally express is staggering, and it is a defining hallmark of the syndrome.
Yeah, that's such an important point.
The exact same severe central hypotonia and apraxia, which is the brain's inability to plan and sequence motor movements that affects the coordination of feeding, also profoundly impairs expressive language. The vast majority of individuals with PURA syndrome are entirely nonverbal or non-speaking. They physically cannot sequence the rapid, microscopic muscle movements of the lips, tongue, and vocal cords required to articulate spoken words.
Oh, and this is so crucial for the world to understand their receptive language is remarkably high. Their ability to comprehend their environment, to understand the words being spoken to them, and to feel complex emotions is vibrantly intact.
We see this beautifully and consistently illustrated in the parent quotes provided in the rare chromo diagnostic documentation.
Oh, those quotes are so moving.
They really are. A mother of a 14-year-old named Aiden noted, "I have learned from Aiden that being nonverbal is not the same thing as not being able to communicate." Another parent of a 7-year-old named Sarah shared that despite only being able to articulate an occasional single word, Sarah has fantastic receptive language skills. She understands everything going on around her and thrives by using a PODD communication book and a high-tech electronic eye gaze device to speak for her.
It's incredible. So when a parent spends an hour doing tedious feeding therapy, working on lip closure, strengthening the jaw, practicing safely managing saliva, they aren't just working on digestion. They are physically strengthening the exact same articulators required for any potential vocalization or speech approximation in the future.
The muscular and neurological pathways for eating and speaking are fundamentally shared. Strengthening the foundation of one inherently benefits the potential of the other. Furthermore, when we actively support their communication through augmentative and alternative communication devices, whether that's low-tech keyword sign or sophisticated eye gaze technology, we see a direct impact on feeding behavior.
Because you reduce the frustration. If a child with severe sensory issues has a lumpy texture put in their mouth, and they have no physical way to say, "This feels terrifying to my brain," their only recourse is to throw the bowl, scream, or engage in self-injury.
Right, it's their only way out.
It looks like behavioral defiance, but it's just a desperate attempt to communicate distress. You give them an eye gaze board where they can look at a symbol that says stop or I don't like this, and suddenly the intense behavioral battle at mealtime diffuses.
It restores their autonomy over their own body. But of course, the journey of nutrition and hydration doesn't stop once the specialized formula safely makes it down the G-tube or past the throat. We have to follow the systemic impact of this genetic difference deeper into the body.
Which brings us to a massive, often under-discussed aspect of daily management. We've spent all this time talking about the muscles in the throat failing to push food down. But that smooth muscle tissue doesn't just stop at the stomach, does it? If the brain signal is too weak to trigger a strong swallow, it's also too weak to trigger normal digestion.
Precisely. We must remember that the entire gastrointestinal tract, from the stomach down to the rectum, is essentially a long tube composed of smooth muscle. It relies on a biological process called peristalsis.
Peristalsis.
Yes, peristalsis is a series of strong, rhythmic, wave-like muscle contractions that propel food, fluid, and eventually waste through the digestive system. I liken it to squeezing a tube of toothpaste from the bottom up to force the paste out the top.
But if you have central hypotonia,
The neurological signal directing those wave-like contractions is incredibly faint. The result is severe intestinal hypotonia. The intestinal walls simply do not squeeze hard enough or frequently enough. The entire digestive tract slows down drastically. Because of this sluggish motility, the transit time for waste to move through the colon is vastly prolonged.
and the longer waste sits in the colon, the more water the body absorbs out of it, turning it into hard, unpassable stones. This is why chronic, severe constipation is described in the clinical literature as a near universal complaint among caregivers of children with PURA syndrome.
It is a relentless physiological battle, and this intestinal hypotonia is severely compounded by the child's gross motor delays and reduced physical mobility.
Because movement aids digestion.
Absolutely. In a typically developing child, the constant physical acts of running, jumping, twisting, and walking physically massage the intestines. Gravity and motion promote bowel motility. But the registries show that most children with PURA syndrome have significant delays in achieving independent walking, and many remain non-ambulatory, relying on wheelchairs. The lack of dynamic, upright physical movement means the gut is left entirely to its own weak, hypotonic devices.
This isn't just about a child having a tummy ache. Severe constipation in a hypotonic gut can lead to dangerous fecal impaction, where the bowel is completely blocked. It leads to vomiting, extreme pain, and can even trigger an increase in seizure activity due to the physical stress on the body. So how is this managed daily?
The management requires an aggressive, multi-pronged, lifelong approach. Dietary interventions are the first line of defense, often focusing on customized G-tube formulas that are naturally high in fiber. However, fiber acts like a sponge. It only works if it has enough water to soak up. If you give a child high fiber without adequate hydration, you essentially create concrete in their colon.
Which highlights the intense fluid management parents have to juggle. Getting enough free water into the gut is challenging when every ounce has to be pushed via a syringe through a G-tube, often while carefully balancing the volume to ensure it doesn't trigger the severe GERD we discussed earlier. It is a constant, exhausting math equation of calories, fluid volume, and gastric capacity.
And even with perfect dietary and fluid management, the mechanical weakness of the gut usually dictates that chronic use of osmotic laxatives is almost always necessary.
Osmotic laxatives like PEG 3350 or standard Miralax. Let's explain how they work because parents are giving these medications daily for years. Are they safe?
They are generally considered very safe for long-term use because they are not stimulants. A stimulant laxative forces the bowel to violently contract, which can cause cramping and dependency. An osmotic laxative works purely by manipulating chemistry.
Oh, chemistry.
Yes. The medication contains large molecules that the body cannot absorb. As these molecules travel down the hypotonic gut, they act like a magnet, drawing water from the surrounding tissues into the colon via an osmotic gradient. This excess water soakens the stool into a gel-like consistency, making it infinitely easier for the weak intestinal muscles to pass it without straining.
But drawing water into the colon means you are pulling water from the rest of the body. Which brings us right back to the hydration math. Parents often have to run continuous fluids through the G-tube pump overnight just to keep the kidneys flushed and the body hydrated while managing the laxative protocols. But the systemic downstream impact of this hypotonia extends even further, beyond the soft tissues of the gut. We have to discuss the literal structural foundation of the body, bone health.
The clinical data indicates that this is a major, yet often entirely silent complication. It frequently gets overshadowed by the immediate visible crises of breathing, seizures, and feeding. But a significant percentage of individuals with PURA syndrome demonstrate terribly low bone mineral density. This leads to osteopenia, which is weakened bones, and frequently progresses to full osteoporosis even in childhood.
Meaning their bones are incredibly fragile. The registries talk about a high risk of pathological fractures, where a bone can break during normal daily activities, like being lifted for a diaper change, or from very minimal trauma that wouldn't leave a bruise on a neurotypical child. Why are their bones so weak? Does the missing Pur-alpha protein directly build bone tissue?
The specific etiology is multifactorial, but the primary driver traces right back to the central hypotonia and a lack of mobility. To understand this, we have to look at a biological rule known as Wolff's Law.
Wolff's Law.
Yes. Wolff's Law states that bone in a healthy person will adapt to the loads under which it is placed. Bones are living, dynamic tissues. They require mechanical stress to grow dense and strong.
Use it or lose it.
Exactly. When a muscle firmly contracts against a bone, or when a child stands up and bears their full body weight on their legs against gravity, that physical stress sends a powerful biochemical signal to the bone-building cells, which are called osteoblasts.
And the osteoblasts build more bone.
Right. The osteoblasts respond to the stress by laying down more calcium and increasing the bone density. But because children with PURA have profoundly low muscle tone, meaning the muscles aren't pulling hard on the bones, and because they have delayed or absent ambulation, their skeletal system is starved of this essential mechanical stress. The osteoblasts simply go dormant.
So the body isn't building new bone, but the problem is actually worse than that because of the medications they are forced to take. Over 50% of these kids have complex epilepsy. How do the anti-epileptic drugs, the AEDs, impact their bone density?
This is a devastating pharmacological side effect. Many common anti-epileptic medications work by altering the chemistry in the liver. Unfortunately, these drugs induce specific liver enzymes, particularly the cytochrome P450 system, that aggressively and rapidly break down and metabolize vitamin D in the bloodstream.
And vitamin D is the key to the castle when it comes to bones.
Yes, you can pump a child's G-tube full of calcium-rich formula, but if they do not have sufficient levels of vitamin D in their blood, the gut physically cannot absorb the calcium. The calcium just passes through the digestive tract and is excreted.
Oh, wow.
So the AEDs destroy the vitamin D, the gut fails to absorb the calcium, and the body, desperate to maintain calcium levels in the blood for heart function, actually starts leaching calcium out of the child's existing bones.
The medication designed to save their brain from seizures is silently hollowing out their skeleton, and this weak structural foundation contributes massively to the severe orthopedic complications detailed in the literature, like hip dysplasia, where the hip joints literally slide out of their sockets, and severe scoliosis.
Scoliosis, the abnormal lateral curvature of the spine, is reported in approximately 48% of the PURA population. The hypotonic muscles of the trunk simply cannot act as a strong enough scaffolding to hold the spine straight as the child grows.
So it curves.
The spine begins to curve and twist. In many cases, it becomes so rapid and progressive that it requires major surgical stabilization. Orthopedic surgeons must go in and fuse the vertebrae together with titanium rods and screws to forcibly straighten the spine.
I am looking at the images from the Frontiers case report in our research stack. The pre-surgical x-rays of the spinal curvature in a PURA patient are terrifying. The spine is completely bent sideways, visibly threatening to crush the lungs and compromise their already fragile respiratory system. And the post-surgical x-ray shows heavy metallic hardware spanning nearly the entire length of the back. It is a massive traumatic intervention.
This is a huge surgery.
But looking at all of this, the slow gut, the failing absorption, the bone loss, leads me to a really crucial question for the parents managing the daily nutrition. If the gut is moving that slowly and the liver is destroying the vitamin D, how do parents ensure their child is actually absorbing the nutrients they are painstakingly preparing and pushing through the PEG tube every day?
It requires an incredibly rigorous, proactive level of medical monitoring. You cannot just prescribe a standard off-the-shelf pediatric formula, set the G-tube pump, and assume the child's body is processing it optimally. It requires a close, ongoing partnership with a pediatric endocrinologist and a gastroenterologist.
Right, the specialists.
Yes, they must track the child's unique growth trajectories, conduct frequent, specialized blood panels to monitor vitamin D, calcium, and endocrine hormone levels, and order periodic DICSA scans to accurately measure the bone mineral density.
And based on that hard data, they constantly tweak the recipe. The parents and dietitians adjust the G-tube feed compositions. Maybe they have to add highly concentrated, specialized micronutrient supplements. Or maybe they have to carefully restrict sodium intake if the kidneys are struggling to process the heavy load of daily osmotic laxatives. They are constantly adjusting the calorie-to-fluid ratio to ensure the child stays nourished, optimally hydrated, and structurally supported. It is highly individualized, high-stakes science happening in the family kitchen every single morning.
And knowing how deeply and intrinsically interconnected the brain, the gut, and the metabolic system are, modern researchers are beginning to look beyond simply treating individuals' symptoms. They are uncovering surprising, truly novel ways that specific dietary interventions can alter the brain's chemistry to treat multiple PURA symptoms simultaneously. This brings us to some of the most exciting cutting-edge data in our stack.
We've talked extensively about the physical mechanics of feeding the muscles, the tubes, the thickeners. Let's talk about the neurological chemistry of the food itself. We established that over 50% of PURA patients suffer from complex epilepsy.
And it is a particularly devastating form of epilepsy. The onset of seizures typically occurs between the ages of 2 and 5. Patients experience a chaotic spectrum of seizure types, from brief myoclonic muscle jerks to massive convulsive tonic-clonic seizures to subtle absence seizures. In many cases, the epilepsy evolves into a severe, intractable epileptic encephalopathy known as Lennox-Gastaut syndrome.
Let's unpack Lennox-Gastaut syndrome briefly. What makes it so destructive?
Lennox-Gastaut is characterized by multiple different types of relentless seizures occurring daily, paired with a very specific slow spike and wave pattern on an EEG. The constant electrical storms in the brain halt or even severely regress the child's cognitive development. And the most challenging aspect is that it is notoriously drug-resistant. Standard anti-epileptic drugs frequently fail to control the seizures.
Because the genetic defect, the missing Pur-alpha, is present in every single neuron throughout the entire brain. You can't just go in with a laser and surgically ablate a single focal point where the seizures are originating. The whole network is unstable.
Exactly. This creates a desperate need for alternative systemic therapies. And a fascinating 2024 case report published in the medical journal Genes highlights a novel nutritional intervention that bypasses traditional pharmacology entirely: the ketogenic diet.
The ketogenic diet, or the KD. Now, most people in the general public know the keto diet as a trendy, modern weight loss fad, eating high-fat, ultra-low carbs, lots of bacon and avocado, but its true origins are deeply rooted in neurology, aren't they?
Very much so. The classic ketogenic diet has been strictly utilized in medical settings for over a century to treat refractory drug-resistant epilepsy. By drastically reducing carbohydrates, which are the body's primary source of glucose, and replacing them with high amounts of specific fats, the body is forced into a starvation-like metabolic state called ketosis.
Starving the body of sugar to force a backup system to turn on.
Exactly. Without glucose, the liver begins to break down fats and converts them into molecules called ketone bodies, specifically beta-hydroxybutyrate. These ketone bodies are small enough to easily cross the blood-brain barrier. So instead of the brain running on glucose from carbs, it begins to run entirely on ketones produced from fat.
Wow.
Yeah. For reasons that we are still unraveling at a cellular level, this fundamental shift in the brain's fuel source has a profound, stabilizing anti-seizure effect in many patients. It quiets the electrical storms.
Okay, so let's look at the specifics of this new case study. It details an 11-year-old female PURA patient. She had a de novo frameshift variant. Let's connect that to what we learned earlier. De novo means it wasn't inherited, it was a spontaneous typo that happened at conception. And the frameshift means a letter was deleted, turning the PURA instruction manual into gibberish, resulting in haploinsufficiency. She had severe drug-resistant seizures, and crucially, she also had pronounced coeluria,
Right.
excessive drooling, because her central hypotonia prevented her brainstem from triggering the swallow reflex to clear her saliva.
Yes. She was suffering intensely from both the severe electrical misfires in the cerebral cortex and the autonomic muscular failures in the brainstem controlling her throat. After standard medications failed, the medical team initiated a strict, medically supervised ketogenic diet to target the refractory epilepsy.
And according to the data, it worked for the seizures. They saw a significant reduction. But wait, this is the part of the paper that genuinely shocked me. I know the KD is used for epilepsy, but the source explicitly states that the diet also resolved her coeluria. It stopped the excessive drooling. How in the world does changing your dietary fat-to-carb ratio magically fix a floppy throat muscle and stop drooling? That feels like an enormous, almost impossible leap of biology.
This raises an important question, and it is exactly why this specific case report was published. It is the very first documented case in the global medical literature showing this dual improvement in a patient with PURA syndrome. While the exact molecular mechanism linking the PURA mutation, the presence of ketone bodies, and the autonomic control of the salivary glands isn't fully mapped out yet, it points to a profound, previously unknown interconnectedness.
We are fundamentally altering the type of electricity powering the brain.
Precisely. The leading hypothesis is that metabolic therapies like running the brain on ketones alter the neurochemistry in ways that go far beyond just stabilizing electrical misfires. Ketones are an incredibly efficient, clean-burning fuel. It appears they may actually improve the baseline efficiency of autonomic nerve functions.
So, to go back to our earlier analogy, the Wi-Fi router in the brainstem that sends the signal to the throat to swallow is defective because it lacks Pur-alpha. But if you change the power source of the router from glucose to ketones, the router suddenly operates just a tiny bit more efficiently. It boosts the weak Wi-Fi signal just enough to send a coordinated message to the pharyngeal muscles, allowing the child to spontaneously and automatically swallow their saliva.
It is a compelling, highly plausible theory, and it underscores the absolute importance of the modern diagnostic odyssey. Specifically, the utilization of advanced diagnostic tools like whole exome sequencing, or WAES.
I was looking at the genetic sequencing data in the sources, and what struck me about whole exome sequencing is how it doesn't just give you a broad syndrome name, it pinpoints the exact microscopic typo in the DNA. It tells you exactly which letter is missing.
That is the power of WES. It sequences all the protein coding regions of a patient's DNA. It identifies the precise variant like the C.127130 deleGTG frameshift mutation in this specific 11-year-old girl. This is the frontier of medicine.
It's amazing.
As our global patient databases grow, we may begin to find patterns. We may discover that specific PURA mutations respond beautifully to the ketogenic diet, while others might respond better to specific pharmacological interventions. Individualized, precision nutritional therapies based on a child's exact genetic spelling error may offer unexpected, life-changing symptom relief that standard blanket medications cannot.
It is a thrilling prospect. Which brings us to a moment to really synthesize everything we have covered today. If you are a caregiver listening to this deep dive, and you are physically and emotionally exhausted from tracking PEG-2 fluid volumes, meticulously mixing thickeners, monitoring bowel movements for impaction, and worrying endlessly about your child's silent bone density, we want to remind you of the core, undeniable truth found in all this complex science.
The daily feeding struggles, the severe neonatal dysphagia, the chronic intestinal hypotonia, the reflux. These are deep structural neurological symptoms of a profound genetic syndrome. They are the direct biological result of a missing protein in the brainstem. They are not in any way, shape, or form a reflection of your caregiving, your effort, or your dedication as a parent.
The interventions you manage every single day, the trauma of the early NG tubes, the decision to place a permanent peg feed, the relentless daily administration of osmotic laxatives, the hours spent in multidisciplinary feeding and sensory therapies trying to desensitize their mouth to textures, these are not signs of defeat.
Definitely not.
They are monumental, life-giving medical tools. They are the exact specific tools that empower your child to grow safely. They stabilize their skeletal health. They permanently bypass the deadly dangers of aspiration pneumonia. And they allow your child to thrive socially and developmentally without the constant distracting pain of hunger or severe acid reflux.
By utilizing and managing these therapies, you are optimizing the physiological foundation they have. You are giving their brain the caloric energy it requires to engage with their eye-gaze communication devices, to interact with their siblings, and to experience the joy of the world around them. You are keeping the vessel strong.
And while you manage the daily realities, the science is moving faster than ever before in human history, which leaves us with a final, provocative thought to ponder. As researchers at incredible institutions like the Jackson Laboratory and JAX Tomorrow successfully develop new, highly sophisticated CRISPR knockout mouse models to study PURA syndrome in the lab, we are getting closer to understanding the exact cellular pathways and the exact role of the Pur-alpha protein.
We're actively moving from the era of basic genetic discovery and diagnosis into the realm of targeted translational therapeutics.
Think about the 11-year-old girl on the ketogenic diet. If a relatively simple, though intensive, metabolic dietary change can accidentally resolve a complex autonomic failure like excessive drooling just by altering the brain's fuel source, what might happen when molecular science finally figures out how to targetedly activate or chemically mimic the Pur-alpha protein directly in the brainstem?
That is the holy grail of genetic medicine.
Could the simple automatic act of swallowing that incredibly complex biological railway switchyard one day be switched on by a targeted therapeutic drug? Could the genetic Wi-Fi signal be fully restored? It is a future that is absolutely worth fighting for and worth funding. Thank you for joining us on this deep dive. We strongly encourage you to take this information, take these case studies about bone health and ketogenic interventions, and discuss these multidisciplinary feeding and nutritional strategies with your child's neurology and GI teams. Keep advocating, keep pushing for precision answers, and know that the science is finally catching up to the reality you live every single day. You are navigating these complex waters beautifully.